Dr. Sophia Lubin, who will give us a talk on selected gynecological problems. She's a graduate of New York College of Osteopathic Medicine and completed her OBGYN at Beth Israel Medical Center, Albert Einstein College of Medicine. She's currently the CEO and medical director of Young Forever Aesthetics in Brooklyn, New York, and she's also on the faculty as an attending physician at Maimonides Medical Center in Brooklyn, New York. So I give you Dr. Lubin.
All right. Well, good evening, everybody. Thank you so much, CAMSA, for having me. And I just like to say a very good evening to all of our distinguished presenters. We will have quite a few things that do overlap, but let's just get into it. I will share my screen. All right, so my talk really is about what can your OBGYN do for you? Most times our first experience with an OBGYN is because of a period issue or pregnancy, birth control, and of course, health screenings. But your OBGYN is also the provider who can help you with so much more. Whether it's as a referral source or for things like your blood pressure, your OBGYN is the champion for the healthiest you. You should consider them as your trusted health provider. And here are some of the health concerns that your OBGYN really can help you with. The goal of this talk is really to emphasize how they can serve as your resource, especially when it comes to improving health outcomes for Black and Brown women. Moreover, what we can do now that closes the gap in the health disparities, bucket. And just imagine the concept here. I mean, when we look at these health concerns, obesity, maternal mortality, and cardiovascular risks, the fact is that Black women are dying at alarming rates compared to their white counterparts. The obesity incidence, for example, white women have about 36% incidence of obesity, whereas for Black women, that incidence is around 56%. These rates are pretty alarming when we look at those kinds of distinctions. And really, it's so multifactorial as to why that's happening. But one of the major ones is just the concept of being Black. But I like to point out these health risks and these health concerns because these are ones that actually many women go to their OBGYNs more than they go to anyone else. And so if we're not the ones who are addressing these things with our patients, then sometimes these are things that can be really missed. And we're the ones who can really help with both the treatment and the management path. So some of the things that an OBGYN is going to think of is your health screenings. So of course, again, just some overlap here, but doing things like getting your pap smear done, a breast cancer screening, management of the menstrual irregularities that can happen, contraception, STI testing, prenatal care, postpartum care, and monitoring and management of other reproductive organs and disorders, such as fibroids and ovarian cysts. So, what does your pap smear actually do for you? And I know some of our other presenters have talked about it, but the point is that your pap smear is there to improve your risk for not developing cervical cancer, basically. It's a screening tool that we use in order to look both at the cervical cells as well as for HPV, the virus that can cause cervical cancer. Oftentimes, a pap smear is combined with a chlamydia and gonorrhea test. The frequency in terms of how often we should have those tests done are every 3 to 5 years, depending on your age, as well as your history. And that really should be a conversation with your provider. And the thing is that as far as pap smears are concerned, there's so many changes that have happened. Most women think that when they're coming to the OBGYN, it's because to have their pap, not realizing that that pap actually can be done, like I said, every 3 to 5 years. But moreover, that they can also have things done that at the time of their annual visit, it's not just for a pap smear. And the concept of HPV vaccination. Actually, HPV vaccination can be done up to the age of 45 because of the fact that HPV, you still have the potential to have exposures, and not just the exposure, but also the fact that HPV can affect so many other areas. So as Dr. Greaves discussed and mentioned, that you can have anal cancers, you can have oropharyngeal cancers that are all related to HPV. And so HPV vaccination is actually quite important. And one other thing I'd like to mention is during the COVID pandemic, which thankfully we're are getting quite past it at this point, but it really widened the gap in terms of care, with people being very lost to care. The good news is that in terms of pap smears, because they can be done every 3 to 5 years, for those women who did not have their screening done in a timely fashion, you know, we have an opportunity to play catch up, number one, and number two, because cervical cancer takes so long to develop, we have the opportunity again to still prevent the concept of cervical cancer really proliferating. However, COVID had, in terms of as a pandemic, has truly widened the gap in terms of care for women, and just increased the disparities. I like this slide, got discharged. Dr. Greaves definitely reviewed for us a lot of great things about what discharge can mean, and of course, in terms of STIs. Many women actually present to their GYNs for the first time because of vaginal discharge or discomfort. And oftentimes it's really a health lesson. It's just a lesson in what's normal. Women should expect that they should have a little bit of discharge on their underwear throughout their cycle. And when I say cycle, I'm talking about their menstrual cycle, with increases in their discharge as they get closer and closer to their periods. And then after their period, that discharge then becomes a lot less, if not gone, and then starts to increase again in the days after their period. And changes around the time of ovulation typically is a good way actually to see if a woman has actually ovulated, is because of that change that happens with their discharge. But of course, the discharge can also mean things that can be very wrong, including STIs, as Dr. Greaves mentioned. And some discharge, though, is not necessarily an STI, but things that just show that you have changes in the vaginal pH. So as he, of course, said, things like BV and yeast. So yeast is a very common infection, but I hate to use it as a term infection, really, because we all carry the yeast. It's just a matter of how much, and the changes in our vaginal pH balance is what allows the yeast to kind of overgrow. And when we talk about yeast, you know, for our audience, I just want to make sure that they understand that when the discharge changes from what's typically your thin, like a milk white type of discharge, to a more cottage cheese or curd-like discharge, that may indicate that you're having an infection, so to speak, of yeast, or the overgrowth of yeast. And that really can and should be treated. And of course, there's the other BV, or bacterial vaginitis or vaginosis, that can happen in terms of that concept, that fishy odor, smell, a more runny-like discharge, that can be very uncomfortable, both with yeast as well as with BV, in terms of sexual intercourse and those kinds of things. And so though that discharge is not really an STD or STI, what it is, though, is quite bothersome and should be treated. So what else should you ask your OBGYN? So as many of our many presenters before me have already discussed the concept of breast cancer screenings, starting at age 40 and should really happen every 1 to 2 years. But one of the things that I think really we need to understand is this concept of knowing our history and why it's so important, especially when it comes to things like breast cancer screenings. So if we take, for example, a woman who may have had a breast cancer at the age of, let's say, 45, and she then has a daughter. Well, that daughter really should be screened or start her breast cancer screening at least 10 years sooner or 10 years earlier. So if her mother had breast cancer at 45, then she needs to be screened at least at 35. And this is an important concept to understand. The concept is that we all really have to do better at not just eliciting the history from our patients, but rather our patients understanding that they need to ask these questions in their families. How come so-and-so, what happened to grandma? Or what happened to auntie? And it's really something that we don't speak of enough in our communities, in terms of really understanding our family history and how it impacts our own screening and how we relate in the world with our providers. Colon cancer screening should start at age 45. It used to be that we'd say, oh, age 50, but really, and especially for our community, it really needs to start earlier. And even for women, especially if you're having, if you start to think about the fact that the disparities already exist, it's part of the reason why we need to consider doing these things as early as we're saying. And as far as cardiovascular assessment, like I said, most women end up going to their OBGYNs. At least we know we're going to go at least that once a year when we, may need our pap smear, so to speak, or birth control. And that's a really good opportunity to make sure that your blood pressure was checked. And just knowing things like, what's your BMI? Am I overweight? Should I be thinking about weight management? So these are the kind of conversations that happen with your that can happen with your OBGYN. And then of course, you want to talk to your OBGYN about reducing stressors in your life. Really, what's your wellness plan? Doing these screenings really helps you to understand the concept of what we, early detection and treatment. And I asked, how did we get through COVID? How did you guys get through COVID? How, here in the audience, how did you get through COVID? And what are you doing to get your immune system up, for example? All right, periods. We have to remember, most women spend 30 to 40 years of their lives getting a period. And your period is not supposed to be something that you suffer through. It's a natural part of life. But for some women, the period means severe symptoms. And those symptoms can be both physical, emotional, and mental. And those are things that you don't have to just deal with or live through, or your family members have to just live with and deal with. It shouldn't be that you miss a day of work every single month because you're on your period. Those are conversations that you should be having with your OBGYN, because that's something that really should be addressed. Whether it's because you may have some other outlying physical disorder or problem with the reproductive tract, or whether it's a hormonal imbalance that needs to be addressed. Certainly, if you're having periods that are so heavy that you feel like you're exhausted after the first day of your period, really could be that you're actually anemic, and that needs to be addressed. And so periods, natural, don't suffer with them, and really address it. We shouldn't just suffer through it. So I couldn't have a talk without addressing the concept of fibroids, especially as far as Black women are concerned, because it seems that, the conversation around fibroids, though a delicate one, really needs to be had, because Black women account for 80%, up to 80% of Black women actually have fibroids. Now, mind you, 70% of women, all women, so that includes white women, that includes Hispanic women, that includes Asian women, they all have the potential and the possibility of having fibroids, but it's a matter of when they're found, or when this treatment occur, or the fact that fibroids, when it comes to Black women, tend to occur when they're at much larger sizes, or when they've become incredibly symptomatic. And so it's important that at your GYN visit, it's not just about your pap smear. It's about doing the pelvic exam so that you can, address whether or not, is it that why am I using the bathroom more often? Is it because you have a fibroid there that's actually pressing on your bladder? Are you having issues with sex? And is it because you have a fibroid that's in an area like in your cervix, or in a posterior part of your uterus? These are things that can be addressed when you go to your GYN visit. But moreover, the concept of understanding that fibroids, actually, you can feel absolutely nothing. So by going to your visits and having the discussion, just ask, doc, I'm so happy you did my exam. Can you tell me, is everything normal? We shouldn't be afraid to have just an open and honest conversation. Oftentimes, especially in our communities, we're scared. We feel like, the doctor is not going to listen, or that the physician is too rushed. We can't stop to ask questions. That they'll think that the questions are too, maybe I'm asking a stupid question, but that's not in fact the case. This is your health. So, like I said, a lot of women come to the OBGYN because they are thinking about birth control. So birth control is more than a pill. It's more than just hormones. Knowing that you have options and making the decision that's right for you and your lifestyle and your health requires a conversation. A lot of women don't realize that there are things like an IUD or something that is long acting, for example, and that it can be without hormones, that there are multiple types. There's a new contraceptive that's on the market now called Phexxi. It happens to be a barrier contraceptive in terms of how it works, and it's just a gel. So it's a gel that blocks, it coats the walls of the vagina. It's non-hormonal, so similar in the sense of how it works like a condom, actually, though it doesn't prevent STIs, but it definitely can prevent pregnancy. So for women who are out there who'd like to have a non-hormonal option, who want a on-the-spot option, but don't want to have, they're in a very committed relationship and don't want to have the physical barrier of a condom, well, that's an option for them. And if we don't start to think outside the box of all of the options that a woman has in terms of her contraceptive care, we're the ones who have to provide that information. And it's a matter of, again, having a conversation. Because if we are not having the conversation about contraceptives, well, in my business, like over this pandemic, I have some women that I've delivered twice, and I have a handful of patients that I've actually delivered 3 times in 2 years, all because of not having an adequate discussion of contraceptive care. I like to, especially in the light of the current political atmosphere, we need to remember that abortion care is actually safe care. And at the end of the day, it is care. If we look to our left or look to our right and think about people that someone has been in a position to consider having an abortion. And that's both men and women, because oftentimes women are not making that decision alone. In light of the controversy surrounding abortion, we have to remember that abortion choices need to be safer choices, especially for Black and Brown women. When we start to think about not having appropriate abortive care, now we're increasing the risk of Black and Brown women actually dying due to unsafe, illegal, um, methods in order to obtain an abortion. And nearly 1 in 4 women in the United States have had an abortion by the time that they're 45 years old. And 73% of women, who actually get abortions around the world are actually married women. It's important to remember that abortion is caring, and we are doctors, we're not judges. And it's a part of all of the care that we give. And even for those of us who have religious objections, then we should at least have an appropriate referral source and system in place in order to still be able to care for our patients. And so that's just what I wanted to make sure that we mention about that. So the disparities bucket, especially when it comes to pregnancy, Black women, we all know it's been all in the news, as if it's something new, but it's not. In terms of Black women dying at an increased rate, 3 to 4 times at 3 to 4 times the rate of white women. And they also have things like preterm births, postpartum hemorrhage, and if we're not our advocate, if we are not the advocate for the patients, then the patients also have to learn how to be the advocate for themselves. Oftentimes, they feel like they don't have a voice, but you have a voice, and it's your voice that's going to help save your life. And so it's important to understand what the possibilities are in terms of advocacy, but moreover, what the problems are going into a pregnancy, so that you already know what questions to ask, how to make it so that you get through your pregnancy the safest. And here, it's just a matter of looking at, when we think about the pandemic, the effect that it's had, it's certainly a scary and traumatic time in our history, but it also has its silver lining, because we actually had an increase in the birth rate. It's for the first time in the last 7 years, we had a 2% increase in the birth rate. But as a result, we also saw an increase in maternal mortality, and again, especially among Black women. The conversation can't stop until we see the numbers fall. And it happens, we have to remember that it happens to all women. It doesn't matter their socioeconomic status, it doesn't matter their level of education. Many of us are familiar even with the Serena Williams story that, she had what's called a near miss. And the concept that someone like Serena Williams, she's famous, everybody knows who she is, and still had the potential to have had a catastrophic event at the time of her pregnancy and birth and delivery. And so, again, it's just a matter of understanding the concept that the maternal mortality rates in this country are dismal when it comes to Black and Brown women, and how we're advocating for them, and how we as Black women can advocate for ourselves. And I just like to highlight what are some of the mortality causes. Just being Black already increases your risk. Things like gestational diabetes, the number of cesarean deliveries, the fact of whether or not this is an unintended birth, being unmarried, and all of these things typically are just the kinds of the concept behind support, and having less than 5 prenatal visits. These are some of the individual risks, and then of course the systems risks, racial bias, and that all plays into things like availability and access to care, and how that affects the maternal mortality risks. We can change the narrative by helping not just because I'm a doctor, but again, as a Black woman, knowing that these risks are there, and how we treat our Black women. It's almost like we should consider almost every pregnancy as a high-risk pregnancy, the same way we would treat a high-risk pregnancy as if you're Black. And so it means that you just pay even that much more care, that you're paying that much more attention to even all the fine details. and not only in making the woman more comfortable, but also in answering and helping her to navigate the system in order to help her just get through the pregnancy safely. Other issues, mood disorders, anxiety, depression, postpartum depression, domestic violence, sexual abuse. These are all the things that your OBGYN is there to help address and be a resource guide for you, be a way to get you the care that you need. And we have to remember that only about 2% of our healthcare budget is actually invested in mental health. And new mothers are at 22 times the risk of admission for a psychiatric illness. So if we're not thinking about moms, if we're not thinking about women in that way, then it's going to just continue these mood disorders, this mental health kind of gap that exists. And of course, COVID-19 just kind of made that situation worse. And I just wanted to point out the fact that now with access in terms of mental health professionals, the fact that we can do things like having this Zoom, or they have access now to virtual appointments. And so encouraging patients to seek care, and even if it's not in person, that they can still have access. And that this is how we're going to kind of bridge the gap in terms of making sure that women not only are seen, but heard in terms of decreasing their mental health disorder risks. The other way. All right, so why are we seeing our GYN annually if we're not necessarily getting pap smears? It's for preventative screenings, yes. It's for family planning. It's for addressing things like wellness goals, a pelvic exam, and the opportunity to identify other issues and concerns. We start from the beginning with education. The more education that the patient feels that they have, that they're getting from you, the more likely they are to trust you. And if they trust you, then we're more likely to actually have a bigger impact on their healthcare goals and their healthcare outcomes, and really be able to improve those goals and those outcomes. Next. And so when we think of like just physician characteristics to look out for, what makes the doctor the person that you're going to love and trust and know they're going to get to all of your concerns? It's having the autonomy, addressing patient concerns, really having the time to devote to your patients. And it's funny, we're in a system where everything is fast, but we have to slow down. And sometimes it means that we maybe say, okay, I can address 2 or 3 of your concerns today. Let's talk about what are those top 2 or 3. And, as patients, you really should kind of have a list. I think one of our other presenters said, make a list of all of the questions that you're going to have for your doctor, even before you go. So that way you can stay on track with what are the things that concern you the most. And from there, it's about having the team. Who's on the team in that office? Who does your doctor have there to help support you, whether it's the receptionist, the nurses, the medical assistants, social workers, caseworkers. And then, of course, it's how is that information being shared in order to really provide the best care for our patients. Next. And ultimately, what is our path forward? Things that are going to help shape a brighter future for Black and Brown women is just things like increased access, using telehealth visits, improving physician reimbursements, and just educating more Black and Brown providers. So just having more Black medical students, nurses, midwives, all of our healthcare providers and people who just look like us to treat us and take care of us is really how we're going to move forward in terms of really providing excellent women's healthcare. Thank you.
Thank you so much. So very informative, and we talk about all the things that affects the disparities when it comes to health and maternal health, mental health, and keeping our Black and brown women safe. So that was very informative presentation. Thank you, Dr. Lubin.